Started. I'll introduce myself. My name is Faith Bonyak. I'm a graduate student at Marshall in the social work department. This is session H3, affirming healthcare for transgender and gender diverse West Virginians, with Dr. Megan Gandy presenting. Just a reminder, go ahead and, like I said, put your name in the chat just to verify attendance. And I'm going to go ahead and turn it over to Dr. Gandy.
Great, thank you so much. I'm going to start the screen share here for us. All right, everybody can see the presentation slide. Give me a thumbs up. Yes, good, thank you. So as Faith said, we're going to be talking about affirmative health care for transgender and gender diverse West Virginians today. I just want to introduce myself a little bit to you. I am a graduate of the University of North Carolina at Charlotte and got my MSW in 2009. And I worked in North Carolina for a couple years after I graduated and got my clinical license working in mostly a psychiatric inpatient unit of a hospital, but also did some community-based mental health work. And then I went on to get my PhD at Virginia Commonwealth University in Richmond, Virginia. And there I studied LGBTQ plus cultural competency. And in particular, I looked at how mental health providers can be more competent with LGBTQ plus youth. And then after I graduated, I went on to become a professor. I started at the University of Oklahoma in Norman, Oklahoma, which is somewhere I never thought I'd be, but I was grateful for the experience. And then I came to WVU about 2 years ago and have really enjoyed it here a lot. I am a West Virginia native. I was born in Charleston, but we moved to North Carolina when I was young. So even though I never lived here as an adult, it's always been in my heart. So I'm glad to be here and really, really glad to be here with you all. In my free time, when that's possible, I like to fly fish and play disc golf. So let's talk about what we're going to do today. What we're going to do is talk about, I really want to get us off the bat by making sure everybody's on the same page. So we'll talk about some basic definitions of gender identity and expression. We'll talk about health disparities faced by that population. And then we'll go into some best practices and resources for you as social workers in the field. And then we'll end the presentation with an opportunity for you to examine your own biases around transgender and gender diverse people, so that you can become more aware of your own educational needs beyond this very short 60-minute presentation. So this was the polling I was trying to do. I just wanted to get a sense of if you have ever been in a training session that focused specifically on transgender people. I know a lot of us have probably attended trainings on the whole alphabet, LGBTQ+, but I was interested in seeing if you've attended a training specifically on that. So if you want to click, I put a link in the chat, so we'll see. I know everybody's kind of answering and doing things in different ways. I'm seeing a lot of yeses, some nos. If you can go to the pollev.com, or you can text Megan Gandy 423 to this number 37607, then that can tell me about what kind of training you've had. So we have our response system here. So it looks like at least those who've made it to the polleverywhere.com platform, a lot of people have attended a training specifically for that population. Now we're getting it about 50-50. Okay. And then I was wondering if this is more, you can just reply in the chat if you've ever provided a social work service to a transgender and gender diverse person. that's just something, the answer for all three is yes. This is a little more tricky since I can't do the polling on Zoom, but I'm getting the sense that we're kind of 50-50 on a lot of this. So I appreciate you giving me that response. That helps me understand where to focus my time here. So I'm going to do a pop quiz here in the beginning, and then we're going to do it again at the end to see where your learning has been. So how does gender identity differ from gender expression? And you can just either jot down your answer or just think about it. And then what is the rate of suicide attempts in transgender and gender diverse adults? And then what is the rate in youth? And then what are the two models of treatment for medical transition? So again, we'll do that pop quiz again at the end of the end of this session to see if you've retained some information. Yeah, sorry about the poll. I think that was a little glitchy, but thank you for your patience and grace with helping me do that. All right, so we're going to start out with some terminology and understanding the fact that these terms are fluid and changing a lot. So the things that I say here today are outdated as of the moment they come out of my mouth, pretty much. It's kind of like scientific research, how things evolve and change a lot, and they especially do with the trans and gender diverse population, which is an excellent thing because we're learning a lot more about how to help folks the best way that we can. So this is a model that's been used. Some of you may be familiar with it. It's called the genderbread person. And you see here, we've got this familiar looking outline, but then we have these specific types of definitions or terms that are located in a particular part of the genderbread person to help you understand it. So gender identity, we are typically understanding that as something that is internal in your mind. It's about who you perceive yourself to be. And so that's contrasted with gender expression, which is how you want other people to see you and how you want them to understand or code your gender. And so I think that's a helpful distinction because some people think, well, they should be the same, but really some people can have a different gender identity and a different gender expression. And that leads into one of the reasons why it's important for us as social workers to never assume that we know somebody's gender, because their gender identity could be something different than how they're expressing. We also have sex, which is in the little genderbread man here in the little groin area, which is not necessarily accurate, but for the sake of the illustration, we'll keep it. And that just relates to what sex was assigned to this person at birth by the doctor, depending on a number of factors, mostly related to genitalia. And so this is kind of our threefold understanding of what makes up the different ways that we understand gender and sex. And so you see this little list here. We have the binary of woman and man, or feminine and masculine, or female and male. And it's helpful to know that some people just simply do away with that binary and don't identify on that spectrum at all. But we do know that over the past traditional history, we see things as binary. And so that's where this image starts us out, is understanding that we have different types of gender identities. Someone might feel more of a woman in their gender identity, but might express themselves more masculinely, but their anatomical sex might be more related to female. And so you can see kind of different combinations here and understand that gender gets really diverse when we start to think about all the possible combinations of how people could or couldn't identify. And then it's helpful just to realize that gender is not the same as sexual orientation. So someone who has attraction to someone of a particular gender is that's not gonna have anything to do with their gender identity. And so we have different types of ways of understanding sexual orientation. We have sexual attraction and romantic attraction. That's not really the focus of this presentation, but just being aware that things about gender don't have anything to do with how someone then identifies their sexual orientation. So with terms, we have the transgender term, and that's considered to be an umbrella term that really covers a lot of people. And like I was talking about before, we have the binary and we have the non-binary. And you can see here some terms that people often use: trans man and trans woman under the binary. And then you have a lot of terms under non-binary that you might have heard or might not have: genderqueer, demi-boy, agender, lots of terms. And again, they come up that I can't keep up with. I learn a lot more every time I do this type of presentation. And I just want to point out on the slide here up on the upper left is the transgender pride flag. And then on the upper right is the non-binary pride flag, in case you have ever seen those and wondered what those were. And so just another image here to further illustrate that the umbrella is broad, and it often includes people who dress as in drag or identify as cross-dressers. And you've got all sorts of this: feminine men, masculine women, androgynous persons. So the umbrella is really broad, but the only people that it doesn't include are cisgender people up here at the top, which is people whose gender identity expression matches what sex was assigned to them at birth. So that's all the time we'll spend on terms and definitions. Next, we'll talk about some disparities. So I want to start with the experience of discrimination in healthcare settings. And I have a short YouTube video to show.
This unforgettable vacation memory. It didn't actually begin here. This memory.
Can you guys hear that?
My name is Leo Sell, and my pronouns are they, them, their.
My name is Sophia Stanford, pronouns she, her.
I'm Gray, and my preferred pronouns are he, him.
Robin Kanawerhaza, and I use feminine pronouns, so she, her, hers.
My name is Luke Jude, and I prefer he, him pronouns.
My name is Chloe Flora. My preferred pronouns are she or they.
"99% of the time when I go to the doctor, I'm anxious and nervous.
Even though insurance and driver's license and everything says female, you really don't know what to expect.
Yeah, I don't think I know any trans person that went through the medical system and had a nice time with it. Not in this country.
I haven't gone to the dentist in 4 or 5 years because it's just such an uncomfortable experience.
I know people who, if they sprain their ankle, will just wrap it up and put some ice on it rather than going to the ER and having an x-ray done because it's just not worth the stress.
I've had a history of urinary tract infections. It was pretty commonplace for me. And I went to the urgent care, and the physician on staff that I was dealing with kept telling me over and over how atypical it was for a man to be having a series of urinary tract infections. I tried to interrupt him and say, I understand, you know, I've been through a gender transition, so my anatomy is probably not what you expect it to be. And he kept stopping me. He wouldn't let me complete and assuring me that he did understand. And he said, I think I would like to take a look. So I pulled down my pants, and it wasn't at all what he expected. And he was immediately apologetic. He said, oh, you don't have, oh, I'm so sorry, I didn't realize. I said, I know, we tried to tell you.
I initially knew I identified and felt female around 5 years old when this was caught out by my family member who was the director of mental health for the state that I lived in, essentially required forced correction. like invasive hypnotherapy, corrective assignment and orientation to gender roles, other things to help masculinize and or reprogram the viewpoint of the world to the child. If I had to be this way, I'm going to walk in front of a car and I'm going to reset it and try over. That's what I thought when I was 6.
I had a bunch of different symptoms tied to sleep, tied to appetite, weight gain, mood, that had sort of increased in severity over a year. And one of the things that my doctor told me to do was check myself into a hospital next time I had my round of symptoms. So I checked into a hospital, and even just within the check-in process, I was misgendered. I finally spoke to the doctor, and he came in and was speaking to me as if I was a 13-year-old girl. And all of my symptoms were surrounding hormones. And when I started talking about hormones, this doctor in the hospital actually looked at me and said, "Oh, what do hormones do? I didn't think hormones did anything." And he actually checked me out of the hospital. He said, "You know, I think that you're just bleeding a lot right now." Fast forward 3 days later from this hospital visit, and I was diagnosed with invasive hormonal breast cancer that tested 99% positive for estrogen. And I think that if I had had the same list of symptoms, but was a cisgendered man, I would have been treated completely differently.
So in general, I've been blessed with a good primary care physician and an endocrinology doctor, but I was seeing a specialist for a different medical problem, and my records and everything all said female. I have everything changed. And the guy looked at it, he went through all of those steps, and then said, "So, do you dress full-time as a woman?" And I was stunned. It's like, "Do you dress full-time as a man?" Yes, I'm a woman. I am a woman of transgender experience. And of course, it's just like any other woman in your office.
The biggest horror story that I had was going to the pharmacy to pick up my first testosterone prescription. I was nerve-wracked already because it's like such an emotional thing to like finally get that golden ticket. It ends up being like $1. So it's just the syringes. There's no medicine. 4 people later, in about 20 minutes, they finally look it up in the computer and they're like, "Oh yeah, oops." Throughout this entire process, I have to say my legal name, which isn't the name that I go by, out loud to the entire store. And I'm basically outing myself to everyone around me. And that's not wanting to hide, that's just about trying to stay safe. Like, some people hear that and they might follow me to my car and bash my head in.
During one physical therapy appointment, I had one of the therapists misgendered me to an entire room of people, both other physical therapists and other clients. He never looked me in the eye again. He never talked about it, he never apologized. It was just this weight. And especially me as a trans woman, I get misgendered all the time. Like, it's something I deal with on a near daily basis. So to have that happen in a medical setting, something where I can opt out of, even though it might not be the healthiest thing, I will. I'd rather protect my own sense of mental health.
So I think that's a really powerful video that really illustrates just how commonplace discrimination is for trans and gender diverse people in healthcare settings. You know, as this data reflects, I'm sure it doesn't surprise you that more than a third of people delay going to the doctor altogether. A fourth have been denied care. A third had to teach their providers. And not only are they experiencing disparities and discrimination at the provider point, but they also are more likely to lack insurance. And people of color are even more likely than their white counterparts to lack insurance. 1 in 20 experienced verbal abuse in healthcare settings, and 1 in 50 experienced physically rough or abusive treatment. So I think this is a very sobering reminder that this is a very real and very important thing to be aware of. And this is why, you know, hopefully why you chose this presentation to attend, because you're aware that this is an important area of practice that we as social workers can intervene to hopefully improve upon. And so the health disparities data also probably isn't surprising, but still alarming and concerning. A lifetime suicidal ideation for trans and gender diverse adults is over 80%, with 40% of those people having had an attempt in their lifetime. With youth, they measure this within a 12-month period, and 52% of those surveyed have suicidal ideation, with about 20% having had an attempt. And so the positive message here is that access to gender-affirming care is associated with a lower prevalence of suicidal ideation and attempt. So in some ways, it's a no-brainer that if we're giving folks access to the care that they need, they are going to have not as bad health disparities. And the disparities continue on with things like tobacco, alcohol. So the tobacco, one study found that trans adults are using cigarettes, e-cigarettes, and cigars at a rate of almost 40% versus about 25% in the general population. Alcohol use, we're seeing one study that says heavy episodic drinking in young trans and gender diverse people, especially those with a sexual assault history. The HIV rates are higher for transgender women. There's a 49% increased odds of having HIV. Transgender men have a lower ratio than women, but they're still higher than the general population. Cancer rates, transgender men are twice as likely to have gotten a cancer diagnosis. And then substance use and mental health disorders are also higher in this population. And people of color are experiencing even higher disparities, with 5 times the rate of HIV in trans and gender diverse people of color than white trans and gender diverse people, and then higher rates of other common illnesses such as arthritis, lupus, and asthma. And so we can see that the stakes are high for these people, that discrimination really impacts their lives, their physical health in a really negative way. Some policy issues to mention. One of the things that you may notice if you follow the news is that we have the presidential executive orders that are supposed to be providing some sort of reassurance to LGBTQ plus people across the board that they won't experience discrimination or be refused care by their medical providers. But the problem with this being coming from the presidential office is that it's kind of a pendulum swing. We had Obama for 8 years, and he came out with some really helpful executive orders that protected LGBTQ plus people and made some incredible policy changes to help ensure the safety of LGBTQ plus people. And then we had 4 years of Trump with really all of that erased, almost all of it erased. And now we have the Biden administration, and a lot of those things are coming back in terms of protections. But you can imagine if you are a trans or gender diverse person, might not really feel all that comfortable with this policy because it could be ripped out from under you with the next presidential administration. So that's why it's so important to advocate for policy change at the legislative level, contacting your representatives and your senators, and really being active with groups like Fairness West Virginia. And if you followed any of the news of the West Virginia legislature this legislative session, you probably saw a lot of anti-trans bills and a lot of things that tried to get through, such as making it illegal for doctors to provide care to trans youth, even though they were consenting and their parents were consenting. That bill thankfully did not get passed, but the fact that our legislators are thinking that this is a good idea is really concerning. One of the bills that unfortunately did get passed was banning transgender athletes. And I'm going to address that here in just a second. Another policy issue is insurance. So health insurance policies and whether or not whether they cover any kind of medical transition vary widely. And some of them don't cover it at all. Some of them don't require a long list of hoops to jump through. And so even if trans folks are feeling more comfortable going to the doctor, whether or not they can get that care paid for is also a battle that they have to face. But it's not all bleak. We do have some excellent strides towards change. For example, we have better visibility and representation in places of power, like Rachel Levine, the first cabinet-appointed openly transgender person in our history. And that was an incredible moment to see that we do have good representation and someone working to make some changes at the government, federal government level. And then, like I mentioned, the Biden administration really coming strongly in favor of supporting trans and gender diverse people. And also, it's great news to know that we have more West Virginia providers that are providing medical and mental health affirming care than ever before. So things are certainly changing for the better, but we have a lot of work to do. So let's get to best practices and what you all can do as social workers. So I want to give kind of a broad view of what kind of services and treatment options a trans or gender diverse person might experience in the healthcare setting, and then talk specifically about what you as social workers might do. And so the first thing I wanted to point out is that the process of any kind of gender's medical treatment is unique to each person. Just because someone is transgender and gender diverse, that doesn't mean that they want surgery. They may not want surgery, or they may just want hormones, or they may not need any of that. Some people never get this kind of treatment because they manage their transition fine on their own. But a lot of people do want that. And so it's just helpful to know that not everybody is going to look the same when it comes to healthcare and affirming treatment options. So the range of treatment is psychological, hormonal, and surgical. And some of the clinical issues that you might encounter as a therapist, for example, is helping someone through the social transition. So helping someone work out how they're going to come out to people around them, how they're going to deal with and cope with discrimination, and help them kind of manage that aspect of the social transition. And then you may also help them through the medical transition if you write a letter for someone, which we'll talk about in a second, or you may just be there to support them. Non-clinical issues that are still important, things that you can do include simply putting a sign of affirmation, either in your waiting area, your office, on your name tag. That transgender pride flag is a great way to show affirmation, and that visibility that immediately sends a message to a trans or gender diverse person that you're safe and that you know what you need to do to make that person feel comfortable with you. Another way to improve care is using charting systems that alert you right away for using the correct name and pronoun for that person. So assuming that they're already in your system and you've already done intake or whatever, if you're able to make it more visible for all of everybody from the receptionist to, whoever is working with this person, let them know what this person's name is and what their pronouns are, so that they don't become misgendered. Or if they do become misgendered, then teaching our office staff how to just apologize and use the correct pronouns or correct name. And that goes along with just the last point of providing education to staff to avoid those damaging misgendering experiences. So we're going to go into a little more detail here. So the medical transition that we see is most often we're seeing hormone therapy and surgery. And this is if someone decides to do a medical transition. We also see other specialized therapies such as speech therapy. And so hormone therapy can be puberty blockers for a younger adolescent who's trying to delay puberty, hormone replacement therapy or HRT. And then the one thing that people don't realize is that a primary care doctor can prescribe hormone replacement therapy for a kid. They can also prescribe hormone blockers. But a lot of people think, oh, it's this special treatment and we need a specialist. But the reality is a lot of us get hormone related medication from our primary care doctors all the time, and there's nothing special about it just because this person is trans or gender diverse. So if you're working with someone and they need care, they may be able to go, if their primary care doctor is informed, they can go to a primary care doctor. And that's a big deal for West Virginia because, as you know, people don't have access to specialists in rural areas, and the only kind of medical provider they may have access to is a primary care. So that's one area to advocate for. Yes, one person says in the chat, getting the PCP to do it has been a whole thing. Yes, getting the provider to do the care that they are trained to do is difficult, and that's definitely something we could spend a lot of time talking about. So the other type of medical transition treatment that we commonly see is chest or top surgery, genitalia or bottom surgery, and then various kinds of cosmetic surgeries to alter the outward expression of the person's gender, the way that they wish to be presented. And then speech therapy is commonly used to help someone if they're trying to pass as someone more masculine or more feminine, training them how to use how to laugh differently, how to cough differently, how to clear their throat differently, so that if they want to have more of those nuances of passing as a certain, under a certain binary, then that speech therapy can be really helpful for that. And as I mentioned before, transgender athletes and the bill that banned them from participating in sports according to their gender identity, I think the concern comes in transgender athletes having an unfair advantage. And research, I'm sure this is probably unsurprising to you, but research shows, scientific research has showed that simply they do not have an unfair advantage. And there's lots of research about that, especially for youth. But then the pro-social aspects of participation in sports are tremendous for every type of youth, but especially trans and gender diverse youth. And so I provide this, there's a fact sheet here by the Social Work College at University of Kansas that gives a nice list of facts and research that talks all about both the harmful effects of these bans and also some really helpful research on how great it is for trans youth to be included in things like sports. So take a look at that when you have time. So the two approaches that we most often see with medical transition, we see the WPATH standard of care and the informed consent model. So WPATH stands for World Professional Association for Transgender Health. And they were the first organization to come out with a standard of care for helping trans and gender diverse people go through the process of surgery. And that started in the 1970s. Can I post the link in the chat? I can probably do that at the end if you remind me. Basically the standard of care started the process of needing a referral letter. And so that was also requiring people to go to a mental health assessment, get a diagnosis of gender identity disorder, or now gender dysphoria. And currently, the standard of care requires 2 different letters and a 12-month period of living in a gender role that's congruent with gender identity. And so if someone is wanting to transition from male to female, then they would need 12 months of living as a female. And so the intention behind the standards of care is to do no harm and ensure that treatments aren't being undertaken recklessly. But in reality, what they really reflect is physicians' discomfort with trans and gender diverse folks. Basically saying, I don't know what to do with you, I'm not comfortable with you, so I'm going to send you to a therapist, and they're going to know what to do with you. And so, as you can imagine, that sends a really damaging message to trans and gender diverse people, thinking that they need some sort of special care in order to do the things that a lot of us get care for every day without seeing a specialist. And so what we found over time is that it becomes more gatekeeping than anything. And if you think about it, you put yourself in these shoes. If you needed a life-saving treatment, would you really be open to talking about all the different things and say all the difficulties, or would you just go in and say what you needed to do to get the treatment? And I think a lot of research is showing that trans and gender diverse people that have to jump through this hoop end up with a distrust of the medical and mental health professionals that they're seeing, because they just feel like they have to be inauthentic in order to get this letter, get the magical letter. And it also has had the effect of forcing people into a gender identity narrative that might actually not be true for them. For example, telling the clinician what they want to hear, telling some story about, oh, I grew up and I was so dysphoric and that this surgery will really help me, when in reality, they may be more non-binary. And so they may not actually explore that with their clinician because they're just concerned about getting that letter. And so they're concerned about telling the clinician what they want to hear. And so that becomes a gatekeeping issue. And it really questions, what is the value of having people do this process? And so over the past few years, another model has emerged called the informed consent model. And this model is actually not new at all, because it's what everybody does for any kind of treatment. I had a surgery recently. I met with my surgeon. We discussed the pros and cons of having the surgery. Then they gave me a form and I checked the boxes and I signed my name, and that was that. And so that's what people are doing now with gender reassignment surgery, is simply the surgeon performing the procedure, having a conversation with the individual, talking about the pros and cons, and then having them have an informed consent document that they sign. And so that model gives a lot more personal autonomy to the individual, being able to tell what are the pros and cons and letting them address that for themselves and with their trusted loved ones. And it also enhances the physician and patient relationship. I'm sure many of you have had the frustrating experience of being kind of the social work third wheel in an experience where you really need the patient and the doctor to get together, but you as the social worker are kind of doing the social work of helping that person along, but really it's a conversation that should be between the doctor and their patient. And then lastly, this can be really helpful for adolescents, because adolescents, lots of identity things are developing, and it allows the doctor to tailor treatment based on that person's age and their level of development. So instead of having a kid have to go through and get letters, if we're doing informed consent with the kid and their parents, then you can tailor puberty blockers at various times. You can try hormone therapy, and that all accounts for the adolescent's physical, cognitive, and psychosocial development. And so the only challenge to the informed consent model, and really any of these, is for adolescents, is it's challenging when the adolescent does assent to treatment, but needs consent from unsupportive parents. And so that's certainly a problem. I see a note in the chat, is there a doctor, or is there a law that stipulates that a patient has to see a therapist prior to surgery? No, there is not a law. It's just a medical standard of care. Now, one thing that you may encounter is insurance. Sometimes insurance, if they do cover the treatment, then they can say, not only do we want you to have 2 letters, but we want you to live 24 months as the other gender and all of this. So even though the standards of care are there, we actually have seen insurance companies requiring over and above the standards of care for people to get gender reassignment surgery. Some other things related to transition, social transition, we're kind of running short on time, I think. So generally, you know, helping someone come out, how they're presenting, and a legal name change. Fairness West Virginia has a great guide on how to help someone go through the legal name change process here in West Virginia. A couple of comments about gender dysphoria. The history in the DSM is long, and we have a lot that we could talk about, but essentially we've moved from having a gender identity disorder to having gender dysphoria. Gender dysphoria focuses on distress that arises when there's an incongruence between the person's assigned sex at birth and gender identity. And so not everybody is going to have gender dysphoria. But some people are, and they're going to have clinically significant distress or impairment in functioning. Best practices for social workers: simply don't assume. When in doubt, ask. You can simply ask, how do you identify, or how would you like to be referred to? Visibility matters, as I mentioned before, wearing something or showing something in your place of work, advocating on behalf of folks and educating those around you, and educating yourself. Next, I have this list of resources. This is in the PDF or in the PowerPoint slides, so you'll be able to access this afterwards, but I just wanted to let you know there's some resources, both here, I'm located in Morgantown, and so we have the Gender and Sexuality Development Clinic through WVU. Dr. Rainbow also lists healthcare providers. Fairness West Virginia has a healthcare guide, and the brand new Trans in the South by the Southern Equality Group also lists folks. And all of these, it's kind of a patchwork, so you kind of have to look at all of them because none of them include all of the people that are affirming. And then sometimes people that are affirming don't want to be on these lists because of the backlash that they get. I think somebody mentioned that in the chat. And then here's some additional resources in case you're working with someone and want to offer them this. There's a trans lifeline ran by and for trans people, and then the Trevor Project and the other hotlines here. So I wanted to end our discussion talking about being aware of your own biases. And, you know, we all come with biases, and it's not something to be ashamed of, but it is something that we're responsible for working on. And you know, we have implicit biases, which are unconscious, and our brains do this to help us process information quicker. So they basically become shortcuts in our brain. And so those are a little bit harder to change than the explicit biases, because those are things that we're aware of, and we can examine, educate, and change our biases. But the implicit one is harder. But there are some things that you can do to work on your implicit bias. So what fuels these biases towards trans and gender diverse people? We have cis sexism and transphobia. So cis sexism is something more on the implicit bias side. It operates subtly, and it's based on the assumption that everybody is cisgender. And so that's one of those first things that you can do to practice battling that implicit bias, is not assuming everybody's cisgender. And then transphobia is more of that active outward bias, hatred, disgust, which, yeah, we definitely are still seeing a lot of that, unfortunately. So some examples of things that you may be doing that you don't realize is sexist, hard to say. Everyday language, saying ladies and gentlemen. That excludes people that are non-binary. So you could say instead folks or everyone. Or if you're used to using Mr. and Mrs., you can say friend or hello. Describing cisgender as quote unquote normal is cissexist. assuming all men have penises and all women have vaginas. And then another one that I think is common is asking for someone's quote unquote real name or their quote unquote preferred pronouns. And the reason why those are not helpful is because the person's real name is the name that they've told you. So if, for example, the person's name in the chart is Megan, but they tell you that they go by Mark, then that is their real name. So you may want to use the term legal name if you really need that information, but otherwise using their name that they tell you is preferred. And then the preferred pronouns thing, it's more in what that communicates. It communicates that pronouns are optional or not that important. And I know that a couple of years ago, it was more common to ask people what their preferred pronouns are, but it's better practice just to ask, what are your pronouns? So taking out the preferred part is helpful. Appearance policing, believing that secondary sex characteristics are indicative of someone's gender. So if someone has facial hair, assuming that means they're a man. If they have breast tissue, assuming they're a woman. Assuming a certain vocal range corresponds with a certain gender. Those things, again, I think they are implicit biases, but they impact how we interact with people. And then assuming that the standard for trans people is to look like a cisgender person, that can be really harmful. And for a lot of people, they don't have that goal. They don't want to look or pass like a cisgender person. And yeah, again, assuming all trans people want to pass. Some institutional exclusion examples include having tampons and pads only in women's restrooms. People that use men's restrooms might also be people that menstruate. So that's a helpful and easy thing to fix, or sometimes easy. Women's spaces that exclude transgender women is excluding those folks from that kind of participation. Forms and applications asking to identify gender with only 2 options, and housing trans and gender diverse people in facilities that don't align with their gender. So what do you do about this? First of all, recognize when you're categorizing people by gender unnecessarily. If you're putting people into groups, if you're working with a group or something, you put people into the boys group and the girls group, maybe that's not that helpful. Maybe you should group people in a different way. And then recognize when you make assumptions about someone's gender based on their presentation. And this probably happens often. You know, every time we go to the grocery store or interact with anybody in general, we're making assumptions about their gender. So that's an easy way to kind of start practicing that rewiring your brain. Using gender neutral terms in general, not making broad generalizations about the gendered behavior of people. So things like only women wear dresses or only men like sports. And then, you know, last but not least, asking people how they want to be addressed. That can be such a simple but effective and powerful way for trans and gender diverse people to feel like you get it. Also, I encourage you to use your privilege, be an ally, listen to and elevate trans and gender diverse voices. Go and seek out stories of people like that YouTube video, or get to know people. I see there's a lot of conversation in the chat about some Facebook groups and other groups. Go and become a part of this movement to help trans and gender diverse people. Call out the cis sexism that you see when you see it, both in yourself and in those around you. Acknowledge when you make a mistake. We all do that. I am certainly the first to make mistakes, but also will acknowledge when I've done that. And I think we all have an obligation as social workers through the Code of Ethics to make our spaces safer for trans and gender diverse people. Another thing on the slides list is the measure of your attitudes. And this is something I wanted to include just for you to use on your own time so that you could go and assess, like, what are my attitudes about transgender men and women? And you may be surprised. But it's helpful to be aware of how one scale measures that. It's certainly not the end all be all, but it can be one way to help highlight where you're at. So we're at the end here. So we've got our pop quiz again. So let's see what you've learned. How does gender identity differ from gender expression? People just want to pop something in the chat. All right, we had our had somebody ready with the answers. Yeah, expression is presentation, how you feel versus how you express, internal versus external. Yeah, I think that's basically the gist of it. What is the rate of suicide attempts in trans and gender diverse adults and youth? Too much. Yes, I agree. That was close. It was 40% for adults and 21% for youth. And then the 2 models of treatment for medical transition. Informed consent is one of them. Yeah, WPATH and informed consent. So we had that standards of care discussion, the bad model and the good model. Yeah. Yeah, informed consent versus WPATH. Yes, sounds like a lot of you got it. These are the answers that we just discussed. So I just want to put in a little plug. I am a researcher at the university and I do research on this area. So I'm right at the end of getting IRB approval for a study that I'm going to be asking trans and gender diverse people to participate in. And so be on the lookout for announcements from the ACLU, Fairness West Virginia, and Pride organizations about how people can participate in this study. And also, if you're interested in opportunities related to the transgender and gender diverse population here in West Virginia, I have a listserv that I'm starting that you can sign up for. I'll put the link here in the chat. Why is that working like that? www.bit.ly trans WV list. So sign up for the listserv if you're interested in staying in touch. So I think we have a few minutes for questions. So are there any things that you wanted to talk about that I haven't covered? Any West Virginia resources for IDD population and transgender? I'm not aware of those resources, but someone else may be aware of them.
I wanted to comment briefly. I used to teach human sexuality, first in the PA program and then at WVSOM. And in the PA program, I ran into some really hardcore religious prejudice and absolute refusal to treat people. And we had to actually go to the dean and had those people, they were almost thrown out of the program, I'm glad to say, but they had to reform. At WVSOM, there was much more openness among the medical students there, and I was very much encouraged by that. I personally treated 3 transgender people and helped them in their transition.
No, thank you for sharing that, and thank you for your advocacy. That's the kind of allyship that we as social workers are obligated to engage in. So thank you for sharing that. I see we have a hand up, so go ahead with your question.
I just wanted to let people know I'm Nicholas Treach. I work in the Eastern Panhandle, and because of COVID, we've been seeing a lot of online work. There is a middle school and high school LGBT group we are doing in collaboration with a local church. And some of our classes and some of the groups will be online, some of them will be in person. But if there are youth who are looking for that, we can be able to kind of connect to that Facebook or that Instagram and find out when they are online. It's something we've just kind of been built grassroots in the community, and it is something that people can do in many other areas. And if you are also looking for different support groups for adolescents and youth, you may want to check with high schools that have a number of the different programs that are pro-LGBT in those areas.
Excellent. Thank you so much for sharing that. Looks like there's some more folks in the chat talking about the, let's see.
I have an extremely long question that would take a while to put in chat. Is that okay if I just ask it verbally?
Yes.
Forgive me for asserting myself. So I'm trying to figure out like a respectful way to word this. So if my language isn't precise or good, please forgive me. But all kinds of like really disgusting anti-trans bills just went through the West Virginia state legislature. And like, you know, I wrote letters to representatives, I called, I left voicemails with Jim Justice. I did every single possible thing that I could think to do, and it still happened. Our advocacy, I'm trying not to be discouraged by it, but I feel like our advocacy kind of went nowhere in state. So what as social workers could we do that we are not doing to advocate better for trans people and get them better treatment? I know that's a loaded question.
That's a great question. You know, I'm so glad you brought that up, because that's really important for us here in West Virginia. One of the things that I have bookmarked somewhere in my long list of things to read is a story of how I think it was Utah. Advocates in Utah and activists were able to talk to legislators and ultimately get legislators to steer away from those kind of anti-trans bills. And, you know, I think that that's probably one of the things that we can do as social workers, is just continue that conversation with our legislators. It does feel like a steep hill with the number of really ridiculous things that come from our legislators. But, you know, unfortunately, I think it's a multi-year, multi-step process. But I think looking at other states and seeing models for what they've done successfully, especially in states that are rural and more conservative leaning, could be helpful. And also just keeping up to date on advocacy organizations like Fairness West Virginia and the ACLU, and supporting them with your dollars and supporting them by participating in their alerts and things like that. Let's see, someone says the Williams Institute used a predictive model for determining the number of transgender teens in West Virginia based on the number of transgender adults. Has that been accurate? Which it was highest in the nation, and are the services available for West Virginia trans teens, acknowledging the school resources the participant shared? So that's a great question. We don't have a way of kind of census tracking the number of trans and gender diverse people, or LGBTQ plus people in general. And so the answer to the first part is we don't know. And I'm not sure if that has been updated. And then, are the services available for trans teens? And I think we've seen a lot of information in the chat about that there's varying resources depending on what school the person attends. But I'm aware that we're running short on time, so I'll drop my email in the chat if you have any other questions. I'd love to hear from you, or suggestions, or other things you want to share. Thank you so much for everybody's time.
Thank you, guys. Thank you, Dr. Gandy, for all of your helpful information. It was very informative. I know I learned and took away a lot from this. So thank you so much for sharing your information.
My pleasure.